Uh, Welcome to this session. Before we start, there's something you want to remind. Remember to mute when you are not talking, so I'm not speaking. And anytime it is possible, switch on your camera and remember to be introduced to the team through the chat. And if you have any question, you can raise your hand. But in a case you don't want to forget the question, you can send it through the chat. Because we have the session today, it's going to last 1 hour and 30 minutes. So as you see on the agenda, this session is about the responsibility of us, as IPC focal person in the healthcare facilities, to engage the hospital leadership in implementing IPC standards. So we are all we are free to comment on our subject, on what we are presenting. So now, as we welcome all, but I can't forget that to welcome some new participant for our session, like those from Cameroon, Ethiopia. So you are all welcome. And thank you, Anna from ICANN, to keep inviting many participants across the Africa. So as we move forward, I would like to introduce our presenters for today. The first one is Dr. Mpunga Tarisis, who is the Director General of Kigali University Teaching Hospital. In French is the Centre Hospitalier Universitaire de Kigali, CHUK. And he's going to tell us about it, as the experienced leader is going to tell us about the vital role of IPC focal points in driving strategic leadership engagement for hospital executive in implementing IPC standards. And the second one is Dr. Marie-Claire Ndayisaba. He's an IPC expert, and he's working at the Kigali University Teaching Hospital. So he's going to present about the WHO IP score components. So after the presentation, we have a time for question, comment, and the feedback. So we still have a few people giving us the feedback about the presentation. So we are encouraging our participants to share their feedback after each session. So dear Dr. Tarisis, you are welcome, as all the participants are introducing through the chat. So you can start sharing with your screen and present about the vital of IPC focal point in engaging the hospital leadership. Thank you.
So please give me the right to share.
I think now you can share your screen.
The host isn't allowing multiple people to share. So, okay, it's now okay. So good afternoon, everyone.
Yes, good afternoon.
My presentation is going to be short because of the time allocated at least 10, 15 minutes, which is not big. So here, I want to recall that IPC definition, which is a practical evidence-based approach to prevent patient and the health worker from being harmed by avoidable infection or hazard in a hospital settings and the other one. So in Rwanda, I think most of us will remember the health facilities have been enrolled in a quality improvement project that we call accreditation program since 2005. At that time, we are focusing for teaching hospital, especially big ones, but going forward, other city hospitals have been joining the program. So at that time, that is where the program on the IPC focal person have been added to the structure of the hospitals. You remember before that period, we don't have IPCs in the hospitals. So when the accreditation program started, that's where people was thinking, who's going to play that role? So in the document, in the SAN document we are using at this time, remember they have 5 these key areas, mostly for teaching hospitals. And these hospitals, most of them. So this area number 4 is dedicating to safe environment for patient and staff. So that's where the IPCs in the focal person normally act on the hospital side. But we can ask ourselves, why do we continue to have issues in terms of outcomes, in terms of infection in the hospital settings, while the program of improvement have started 10, 20 years ago? So it's because we still have challenges. Those challenges depending on the level of the structure of the institution, even for the country. So most of the challenges can be, I tried to summarize it in 3 areas. Most of them, some of them related to the system itself, others are institutional or patient-related challenges. So when talking about health systems, we are referring most of the time on resources. So most of health facilities, they have few resources to implement, to build, to buy equipment. So we are having issue of number of patients who are coming in hospitals with infection, with different diseases. So we have issue of guideline policies, and even people who trained in that area. So when it comes to the institution challenges, here we're talking about duration. How do we, when we are looking about in terms of health facilities, staffing and people they are receiving. So we see most of them, they are overcrowded and the staff are not sufficient. One nurse can at least take care of 20, 50 patients at the same time, which comes a challenge for taking care of them, and also applying the standard at that level. So we still have issues of infrastructure. Space is an issue. So equipment still a problem. All those issues are still there and are affecting the quality and the safety of health professionals and the patient at the same time. So when it comes to the patient, of course, there is the issue of disease burden, there's the issue of nutritional status, and also there's an issue of this high usage of multi-drug issues. You see, there's antibiotic. Now we are talking about the antimicrobial resistance as a public health concern because of people that are taking antibiotics in a way that are not coordinated because of structures are not well developed to make sure that we are applying an antibiotic which is really tackling to the right antibiotic germ. So now, the role of IPC, normally for me, I understood it. Someone who has this knowledge and the capacity to be able to influence and also to engage all stakeholders. When you are talking about all stakeholders, it's all levels of health facilities implementation levels. So we have clinicians, we have health workers, we have cleaners, we have security people, we have clients who are coming here, but also we need the leadership to be involved in this. Sometimes, normally when the head is sick, the whole body has a problem. So now that's why we are focusing on the leadership. So when the leadership is strong, now the rest of the things are working. Not even with few resources, we can be able to navigate and to prioritize accordingly and to minimize that risk for patient and healthcare. So there is a way to engage them. Normally, to be able to attract the attention of people, especially leaders, you need to give them clear information. So how can we demonstrate that actually the outcome for our processes, our business, our patient care is not really what we expect. So people maybe they are dying for infection, people they are not getting the right treatment you want. Health workers, they are not applying the standards. There are issues in the hospital. If you can be able to document this and provide the evidence, then now we wake up the leadership to take care of that because of now their position will be affected because of the outcome is bad. Therefore, they're going to be responsible for that. The accountability now comes from there when they are seeing that things are going wrong. Therefore, they have to act on that. So from there, you will engage them to think about how can we solve the problem we are identifying. So we'll be able to create clear action plan with clear activities and responsible people, and also there's a budget behind. So from there, now the leadership will be able to allocate resources depending the issue they are facing. Now they're going to be prioritize how to address that problem. You may not see someone who is interested by having meetings, who want to make some visiting, who not be cared for. Why don't have stock out? Why don't you have linen in hospitals? But when they have been able to demonstrate that you have a problem, that's where they will be able to act on that. Therefore, it comes for the implementation. So when it comes to implementation, we need to be able to be more engaging people, other stakeholders, other professionals. That's where communication issues comes. So once you have clear problems identified, clear plan, but the implementation becomes a problem because of the communication, the engagement is not well transmitted across the whole level of hospital structures. So now the focal person, the focal IPC, someone who has this knowledge and the skills will be a vital, will be a driver for this to be able to interact and also to help people to engage this one. Lastly, when we are implementing, you have to monitor and to report progress. Let's say you have a quite improvement project you are implementing. So we have been able to convince the leadership this is a problem. For example, we have a high C-section infection in maternity, for example. Mothers are dying, they are having infection, they are staying for longer in the hospital. So we have been able to demonstrate this one. Or we have some mortality rate which is very high in the ICUs or in NICU department, for example, for newborn. So when you have this clear roadmap and the plan to implement, the leadership will have allocated some resources, the people to help you for implementation. Now comes back with a good plan for monitoring and the reporting on the progress. That's how we can engage the leader. So once the things are going with good improvement, you can see now the leadership will be able to clearly understand and support that areas. So this is how I think focal person can be able to navigate in this very complex business in a hospital where there is a competing activities where and the resources which are not very limited, how to engage the leadership of the hospital to be able now to understand how they can focus on this improvement. Thank you.
Thank you, Dr. Tarisis, for this interesting guidance. Many of us as the IPC focal person, we didn't know how the best way to approach the hospital leadership so that they can be engaged in the implementation of IPC, because IPC is not somehow directly the services of IPC, some are not paid by the patient, and something that if those are not contributing to the increasing of the hospital or income, maybe we will not be interested in implementing such activity. So through this way, I think as a IPC focal person from Rwanda Health Care facilities, they are now aware of the best way of approach the health facility leadership to implement the IPC standards. I don't know if there is someone who has a comment or feedback about this presentation, so she or he is welcome. Is there anyone who has a comment about this? Yes, Obino.
So, good afternoon, everyone. It depends where you are. So, my name is Obino Chai. I'm from Kenya, currently working as an IPC coordinator in one of the counties. So, in Kenya, we have counties, or we can call them states. So, my observation is that in many countries, we are having national action plans. And national action plans for IPC, they should are adopted by our Ministry of Health or Department of Health. Why is it not easy for this national action plan when it is developed, so that it is sensitized, so that it reaches up to the first level, so that we don't again have to find ways on how we can reach the facilities so that they know about IPC. Was a problem with the national action plans on IPC? Maybe a comment from Rwanda.
Tarisis, can you?
So thank you very much, Mr. Obino. Obino?
Yes.
Yes, I have been in Kenya, know how some country are working. So let me tell you something. So every country has a different context, and the implementation depends on how the Ministry of Health and the health system is organized. For example, if I give you an example, at Rwanda Ministry of Health as of now, we don't have an IPC policy already approved by the government. So this is a barrier. It is a barrier because of IPC people, they are not taking it as a serious concern. Maybe because of the education background, but also because of it require some resources and some evidence-based, which is not really easy to demonstrate. If you go to a health facility level, for example, seeing, and I think it's the same in Kenya. So you may find some issues which related to the procedure, how people are being treated in accordance of guideline and those principles of IPC standard, which are not really applied as required. So we're ending up having bad outcome. But in reality, how many are assessing this and making this a noise? Look at this, you are not applying IPC measures, you are not applying quite of their guideline. So therefore you have these problems. So what is the issue behind? We have a high of health professionals in countries. And even those who are there, sometimes they are new. Once they're spending 2 years, 2 months, they're leaving, new are coming, and also they are being, the continuity is not there, and there's no clear documentation that way. So once the principles of IPC are not standardized in a country way, becomes a problem where they have already taken that step to make this national action plan. The implementation does not go immediately like that. So I have been in East Africa meetings for several times. So you see how people they are discussing about health issues. You see there's not that connectivity, that seriousness not there. So we can transition from the policy to the implementation, it still have a big gap. So this is how I can respond to the question.
Okay, thank you. So the next is the presentation from Dr. Marie-Claire. So can you share the screen for the core component for IPC core components? Okay. Over to you, Doctor.
Sorry, Jean-Jacques, can I just ask that I put it in a slideshow mode? It's easier for the presentation for people to read then.
Sorry?
Just put it in the slide. There we are. Thank you.
Okay.
Thank you. Good afternoon, everyone. Good afternoon. Can you hear me?
Yes.
Good afternoon.
Good afternoon.
Thank you. I'm so honored to give this talk today. This is almost the core or the basis of IPC. As we heard from the Dr. Munga, IPC is like a hot topic, a new topic in our health setting, it is not that old. It is started to be boosted due to different outbreaks that are happening in the region. However, implementing IPC is one of the key measures to treat our patients, to give them safe care in whatever we are doing. A little bit comment about the dissemination of national guidelines, implementation in different healthcare facilities. I think it is the limitation is based on limited awareness of the role of IPC, but also the fact that IPC is now becoming a core component in a healthcare setting. And another issue is people are not seeing the impact directly. They are busy with acute or complex problem like malaria, like trauma, like accident, and they forget that any treatment that they are providing can be affected by poor hygiene or poor infrastructure in the healthcare facility. Today, what we are going to discuss is the key elements that anyone involved in IPC as well as involved in healthcare must know so that they can implement IPC in the healthcare facility, but also some component at the national level so that we know what we are doing, what we are monitoring, and how we are implementing different projects that are targeted to improve IPC in our settings. So we are going to present WHO IPC core component that we base on to build strong IPC program. So IPC program is a systematic program which is made by defined way to prevent and control healthcare associated infection, antimicrobial resistance, and infectious disease outbreaks. IPC program is a cross-cutting program. It affects every aspect of patient care, and it is applicable in all patient care settings, meaning hospitals, pharmacy, as well as beyond human health. Now we are going for One Health, where we involve environment, animal, and plants, as well as human component. WHO has defined IPC core component. These are the key elements that we have to consider when we are implementing IPC principles, and those components must be implemented together to build an effective program. In this module, then we are going to discuss those components, and we are going to see how we can do improvement project for IPC or improvement of practice. So we are going to see the definition of IPC program, the core component of that program, so that we help the administration, IPC officers to see where they are from this core component in the implementation of IPC in their facility. And we are going to see the approach that WHO recommend to implement IPC core component, but also to improve the practice. Therefore, everyone should know the IPC core components defined by WHO that serve as blueprint for successful implementation of IPC program. They will be able to describe multimodal strategies to prevent infectious disease. It is a cross-cutting. It means that it is not limited to one department. It is not limited to the laboratory only or to the internal medicine only. It is cross-cutting throughout all the programs that are happening in the hospital. And then each person in the healthcare setting must be involved for sustainable and successful improvement. The IPC program must have clearly defined roles and responsibility of each key player. They must demonstrate administrative support because we are going to see it requires finances, it requires support from different participants at the hospital. The program must outline oversight and accountability for each activity that are being done in the hospital. And at the minimum, the IPC program must have resources to run the activities related to IPC. So what are the core components now do we have to have in our program so that we know what we are doing? We start from this point, we are heading to progression. So the IPC core component, it has been defined and released by WHO, World Health Organization, in 2016. And it is a blueprint. It is like a map that we have to use to make sure that IPC program can be implemented effectively and can prevent the harm due to infection as well as antimicrobial resistance. Therefore, we have 8 core components that must be in place, but also evaluated continuously to see how strong the program is working or how good the program is. At the national level and the hospital level, we must have an IPC program. We must have guidelines. We must have a program for education and training. We must do healthcare associated surveillance. We must implement different interventions to improve our infection prevention control using multimodal strategy. And we must do monitoring of our interventions. We have to do audits, and then we have to give feedback to the people we are auditing. At the facility level, we add these 2 other components, the workload, staffing, and bed occupancy, as well as the environment, material, and equipment we use. But at the national level, we have only the 6 core components, the first 6 core components, but at the facility, we have all 8 components that must be in place to ensure that we have a functional IPC program and then to start to do monitoring. We are going to see in detail the summary of each component, what are really required to have the program. If we see on this picture, as you have seen that this IPC program, it is a systematic way of controlling infection, and you have different components that has to work together to make the program successful. The program itself must be there in the facility or at the national level. That program must have the policies and guidelines that dictate what must be done. The guideline must be communicated to the users and stakeholders. We have to do surveillance of infection. and antimicrobial use. And you have to do monitoring, audit, and feedback. However, we must have an enabling environment, which means workload, staffing, bed occupancy, and environment, as well as material equipment. All this program or whatever we are implementing, we have to use a multimodal strategy so that we ensure that any intervention that we put in place for IPC, either at the national level or at the facility level, it is sustainable and it is accepted by the users. Therefore, what do we expect to have in IPC program? When we say IPC program is in place, it means when we come to evaluate either the national level or the facility level, we must have clear objective of the program. We must have clear definition of function and activity of that program. We must have people who are responsible for those activities. We must have funds. So at the national level, the national level IPC program should be linked to other relevant national program. For example, if you have a program for outbreak management, if we have a program for antimicrobial resistance and antimicrobial stewardship, if you have the One Health program, if you have infectious disease program, IPC must be linked with those other programs. But also, it must be linked to professional organization for maximum efficiency. Because we have seen that IPC, it is a cross-cutting program that involves many key stakeholders and many key players to make it successful. And this national IPC program, normally it is responsible for making the guidelines, as we have said, the national guideline, the strategic plan, the nationalized data of surveillance, and also be responsible to monitor the activity of different other IPC programs, specifically at the healthcare settings. So what do we have at healthcare setting? We should have dedicated, trained team of IPC professionals. Those are the people who are going to implement different activities, coordinate different activities of IPC that are envisioned at the healthcare facility. So a well-functioning program with a clear overall vision outlines. This vision outlines what is to be done, where that activity must be taking place, how the activity is going to be done, and when each core component is supported, interact, and progress. Because we have seen that we have different guidelines, we have the training, we have different activities that IPC must do. So we need dedicated people who are trained. In both national and healthcare facility, there must be specific resources dedicated toward IPC program because each activity requires funds. That's why involvement of all stakeholders and other supporters of the facility or the national program must be involved in the planning as well as in implementation of different strategic plans that are envisioned. The second core component that is required now at the facility or national level, we have already dedicated people. So we have to start guiding them. We must have a guideline. So the guideline are the key IPC principles to guide best practice. It should describe evidence-based guidelines which are developed and implemented for the purpose of reducing healthcare-associated infection and antimicrobial resistance. For the maximum uptake and correct implementation, healthcare workers should be trained on IPC guidelines recommendation. So it is not enough to have the guideline in place in paper. We must train the people who are required to use those guidelines. We must have processes in place to ensure that healthcare workers in the facility are educated and they understand this guideline that are guiding their practices in regards to IPC. We must also ensure adherence with this guideline, and the adherence should be monitored, not just to assume that people are using the IPC principles. We have to monitor, and this monitoring is done by the IPC focal person in conjunction with hospital management, because they will need tools to be used for the assessment, but also they have to give feedback. They have to plan for improvement based on the gaps they have identified during the monitoring. The third component is education and training. IPC practice and principles. We have seen that one of the gaps we have at our level is limited knowledge, limited awareness, and the program must have a way or a planned way to train and to educate the healthcare professionals, but also the supporting staff, the administration staff, and at the extent, the community. So a successful IPC program implements education and training for healthcare workers. At a national level, this is where the major planification happens. It is better that IPC program at the national level collaborate with local academic institutions to ensure that the training standards are being met. This means during the formal training of healthcare professionals, national IPC program should work with the academic institution to put the modules of IPC in the standard training so that the people they graduate having knowledge of IPC. At the facility level, it is best for participants to have hands-on experience in best practice to reduce the risk of healthcare-associated infection and antimicrobial resistance. Here it is where we do, in our setting, for example, we do initial training for the new staff, but also we have continuous training for the staff in place already at work. Here, the staff, they get hands-on training. We do not give only the formal presentation, but also we do the practical sessions so that they assimilate the knowledge by doing, and to ensure that those practices are put in place and they follow them. Therefore, healthcare workers at all levels of education, individuals at pre-service and in service level must be supported in IPC education and training. To increase improvement, the impact and effectiveness of training, this program must be also monitored. When trainees are acquiring the knowledge, how are they using them? We must have attendance list, evidence that we have trained people and they are gaining knowledge and they are applying them. Evaluation of education and training must be done. The fourth component of IPC program is healthcare-associated infection surveillance. At the facility level, this associated infection and IML is conducted to guide IPC interventions and outbreak detection. As Dr. Munga has mentioned, we have most of the resistance in the high risk in patient admitted in ICU or patient having the invasive devices. It is our role as IPC focal person to highlight that problem so that we look for intervention to reduce those infections in our setting. But also, IPC focal person, through the surveillance, they found at early time any potential outbreak in the hospital. When we do the surveillance, we must provide timely feedback of the result to the healthcare in the facility. And we must also engage likelihood that improvement will be done. Because if you see there are infections in a patient who are in a ward of many patients, we need to give the feedback area so that we start limiting the infection that is going on at that ward, where to protect other patients. Otherwise, if we do not give immediate feedback whenever we have seen the infection, it is going to spread and reach the level we cannot control. So the role of surveillance is to detect the problem area at the time we can manage it easily. Therefore, surveillance information can be used to evaluate the local situation with regard to healthcare-associated infection and compare the facility data with national and other facilities data, which in turn can provide justification of allocation of more resources to different facilities as the need has been highlighted by the data collected during surveillance. Surveillance is so important because it is going to affect how we are going to use the budget allocated for infectious disease, like buying drugs, vaccines, laboratory testing, or construction of hospital if we need more isolation. So it means surveillance is the first tool that we can use to detect infection, but also to guide in resources allocation. The fifth component is multimodal strategy. So here we can ask each and everyone, how do you implement an IPC activity in your setting? I think this component has been put because we do the surveillance and we propose the solution, but it does not last, or it is difficult to monitor or to sustain the improvement activity that we have suggested to be implemented to stop the problem. Therefore, WHO suggests that it is better to use a multimodal strategy whenever we want to implement any intervention that is put in place to improve practice and reduce the infection in the hospital. So a multimodal strategy consists of 3 to 5 elements, and they are implemented in an integrated way with the aim of improving an outcome and changing behavior. When we bring in behavior change, it means we are targeting long-lasting or culture change in our practice. A multimodal strategy includes tools that we are going to use either for monitoring or for tackling any problem, such as bundle of care. We are going to see the different bundles when we are going to discuss different categories of healthcare associated, the different procedure we use to prevent or to treat the healthcare associated infection. This strategy also includes checklists. For example, if someone wants to put in an IV line, intravenous line, you have different steps that you have to follow. Having a checklist, it is going to help the practitioner to check if each point has been done and done well with the respect of IPC principles. And we have this tool, they are developed by multidisciplinary teams that take into account the local conditions. In detail about multimodal strategy, as you have said, that it has 3 to 5 components. The 5 most common components, it is system change, education and training, monitoring and feedback, reminders, and culture. These are the components you look for when you want to implement any intervention targeting to improve IPC practice in your settings. For example, someone wants to have done a monitoring of hand hygiene in the hospital, and they find that there are different gaps. And then they say, I've visited one hospital and I find that the compliance to hand hygiene is higher because they have put alcohol-based hand rubs at each door of the facility, of each room in the facility. And you want to bring that practice in your setting. You have to target these five, you have to include these 5 components. You must have to check if the system you are working in is going to support your new intervention that you are going to introduce in the setting. You have to check, are there available appropriate infrastructure and supplies to enable IPC good practice that you want to introduce? If they are not there, is the time now to advocate, work with the administration, and then find out how to improve those infrastructure. Coming back to the hand hygiene, you are going to check, do we have the handle for those alcohol-based hand wraps? Do we have the solutions? Do we have the containers? Do we have personnel who are going to teach how to use those hand wraps? And then, if those infrastructure cannot support the intervention, those are the intervention bringing then, and then they fail because you have not considered, is the system you are working in, are the infrastructure supporting the intervention I'm going to put in? Or can we improve the infrastructure to support the intervention we want to put in? So coming back to the hand hygiene, the intervention you want to put in, you must educate and train the users, the healthcare professionals, as well as other key players. For example, you bring in those hand rub at each door. The system is okay. You have already installed those bottles at each door. You have already put everything, but people do not know to do hand rub. So it means your intervention is going to fail. That's why you have to think about the education and training. You cannot train on the people without putting the infrastructure. That's why this multimodal strategy, you are going to see, it is very thoughtful method that we are going to be using while we are bringing in different interventions. You must have monitoring of those infrastructure. You have to monitor the practices. You have to monitor the processes. You must monitor outcome and providing data feedback. Coming back to the hand hygiene, you must monitor if you have already put the hand rub technique to each door of the hospital rooms. You must check if people are washing hands, are doing that hand rub. You must monitor and always check the alcohol, is the alcohol there? Are the necessary equipment for that intervention available? There's no stock out. Is the process itself not complicated so that people are not adhering? Is this intervention that I have put in place improving the outcome, or it is just there? I've been lost here. Can you hear me now?
Yes. So, anyone who has a question about this setting up of the IPC program, including the national level to the level for healthcare facility. So I see the problem of the internet. So anyone who has a question, a comment, or yes, Obino?
So, okay, sorry, I'm having a lot of questions, but I know it is a learning
So
session. Huh?
you are welcome, no problem.
So I don't know if I pronounced the name correctly. So that was Ndaisaba. Hope I pronounced it correctly. So that was a very nice presentation. Huh? But I just want to learn experience from Rwanda. Do they have like indicators that like they monitor regularly, that's monthly, and we can be able to access them maybe in a health information system? Because if we have indicators that we are measuring each month, when for example, the program HIV, let us say HIV program, they should have some indicators like thyroid suppressed, current on care, something like that. So in IPC, maybe I just want to know if they have indicators. They usually measure each month. And if you have these indicators, you are likely to people to see what you are doing. So do you have any indicators that you measure every month from all these facilities? Thank you. That's just like a question, but they have, yes.
Okay, thank you, Obino. So the IPC program and the indicators for monitoring IPC practice is not yet, and all the indicators as recommended by WHO are not yet entered in the health system, HMIS, health HMS, which is the data managing system in Rwanda. And that's why we want to make an advocacy for the challenge we have in the healthcare facility in Rwanda, so that the IPC indicators as recommended by WHO should be among the data we are monitoring in the HMIS, like HIV is in advance. All the data about HIV are monitored monthly in the HMIS, and the other program like maternal child. All those data are in HMIS, but for the IPC program, they are not in the HMIS. So we brought this program. One of the responsibility of our program is doing the advocacy, so that the indicators for the IPC should be in the HMIS, so that they can be recorded and reported for monitoring electronically. So, Tarisisi, if you have anything, or Dr. Manzi, you can add something.
So maybe the IPC focal person would be able to answer that question. So at national, first of all, the impact of IPC measures or procedures standard in hospital implementation, their measurement are always indirect, because we measure the outcome of the patient, what is happening, what is the result of taking care of patient all the time. So in our HMIS, we have some indirect indicators which can help you to understand how people are implementing the IPC guideline principles. Normally, we're reporting number of deaths, especially for women, the children, and others. Also, the infections. So let's say if you want to see the post-C-section infection rate in a hospital, you can go in the system and you get it. Some of this. So if you go to the surgical department, and also you have the rate of infection, death, and so and so. But at national level, we have a few indicators who are linked to the outcome. But at the hospital level, we have this program, the accreditation program, where the IPC component have a clear indicators they have to monitor and report on a monthly basis. So this is how I could answer the question. Thank you.
So that's well noted. And I think we also struggle in Kenya in matters of monitoring, but currently we are able to do surgical site infection. We have a register and hand hygiene register, but actually the healthcare workers need to be sensitized more. And this is not being done in all the hospitals. So maybe in future, we really need to come with the indicators which cuts across. And for this, I think we can be able to monitor our program and we can be able to mainstream it and do some advocacy.
Sorry.
To support our implementation. So, Dr. Krell, I don't know if you are now available. We're discussing about the Kenya team. Were asking where we are at the level of implementing the monthly monitoring and evaluation of IPC indicators. So if you have anything to say before we proceed, so over to you. Hello? So I see still have challenge of the internet. Did you listen to my question? Okay.
Dr. Jacques, so
We can't
okay,
hear Dr. Krell.
Unmute. Sorry. Okay, sorry. I was muted. Sorry. That's why I couldn't communicate. I'm sorry for the interruption by network. So I had the question, but the implementation is done by like facility by facility. It is not, I may say it is not national-wide well followed, but we have a system in HMIS where we report some healthcare associated infection, but I may say that the reporting is not systematic and it is not including all the healthcare associated infection. We need improvement in the process. That's what I can comment. So, do you see my screen first? I don't know. I'm now having issue with screen sharing. Dr. Jacques, can you share the presentation, please?
maybe Jacques could give you the right to share.
I got. Do you have it now?
Yes, we have.
So I'm sorry for the interruption by network, but we were seeing the multimodal strategy of implementation where we have to build the system so that we can sustain the intervention that we want to put in. You have to teach that intervention you want to put in. You have to identify who need to be trained and then what type of the training that must be done. And then does the facility have trained people to use the equipment or what you have put in place? You must check the intervention, how people are adhering, and identify different gaps in that practice so that you can improve the intervention that have been put in place. And then you have to sell it. You have to sell the good practice. You have to communicate to people. You have to remind them that they have to adhere to the intervention that you have put in place, and then you have to leave that culture once the intervention has reached the level where the healthcare professionals have now understood the role of that intervention that you have put. But this one is to to reach the culture change, senior management should be incorporated as well as champions or role models for the IPC implementation must be congratulated and then also help to strengthen the intervention adherence for other healthcare professionals. So the sixth component is monitoring and audit and feedback. This is different from surveillance. Surveillance is done for healthcare associated infection and antimicrobial resistance monitoring. But here we monitor now the practice. We monitor, for example, hand hygiene. We monitor adherence to care bundles. We monitor adherence to different protocols that were put in place, how people are adhering to different guidelines. And then we monitor not only the practice, we monitor the infrastructure required for each intervention. We monitor the knowledge at individual level as well as at the facility level. And then we have to provide feedback. We not only give feedback on the status of infection, but we give also feedback on the performance of the professionals. And then we congratulate the good practice. At the national level, evaluation of the program should assess to what degree national standards are being met in the activities performed. The criteria should be based upon the goals and objective that the program has. That's why at the beginning we have said that the program must have objectives and goals. And for example, if it is hand hygiene, you have to do hand hygiene monitoring. Hand hygiene is one of the key strategy we have now to fight the antimicrobial resistance because the development of antibiotics is very slow. And then whatever antibiotic is brought to the market get immediate resistance. So hand hygiene is one of the tools that should be incorporated in key performance indicators for healthcare professionals, but also at the national level. And then the core component 7 is workload, staffing, and bed occupancy. This component regards only facilities because there we have the patient, the staff, and then the care we provide. Immediately understand if we have, for example, one nurse who has to attend like 15 patients post-surgery, she has to dress the wounds. She will not have the time to implement IPC as it is required, the principles. She's going to skip hand hygiene between patients. She's going to skip some good practices. Therefore, we have to check, is the workload we have in different wards or in different patient stay goes with the staff we have. Do not have staff who are suffering from overworking. And we must check the bed occupancy. We have the challenge of having limited bed in our settings. When we put two patients on one bed having different diseases, there is high risk of increasing infection. Therefore, healthcare administration must check bed occupancy and staff factors because if they are well balanced, they reduce significantly cross-contamination and ultimately reduce the healthcare associated infection as well as antimicrobial resistance. Bed occupancy should not exceed the standard capacity of the facility, and healthcare staffing should be at acceptable level in relation to patient workload. Attention must be paid to bed occupancy and healthcare staffing, improve the quality of care, not only for the patient, but also for the staff who provide the care. At the facility level also only, this does not regard the national level. We have to see the environment, built-in environment, materials that we use, equipment we use in our care. All patient care activities should take place in a clean, hygienic, well-ventilated, well-illuminated environment. So the facility should implement actions that support this environment, including adequate availability of water, sanitation and hygiene, infrastructure, and services. IPC materials and equipment should be provided. For example, if you implement hand hygiene using hand washing, you must have all the components, water, soap, and the towel, and the dustbin. Running water must be continuous. The towel must be always there. So we have to ensure that environment also support the staff to adhere to IPC. And then, when possible, centralize the production and distribution of required supply, such as alcohol-based hand rub and soap, can be effective. This regards to when one healthcare setting must have a different procurement line compared to the other facilities. This can be a burden to the suppliers. But when one supplier can supply to many hospitals at once, it is easy to trace to have continuous supply, but also to trace where the problem is, specifically when they have supplied inadequate equipment. For example, sometimes they supply the injection safety box, which are not adequate. Now it may be easy at the national level to trace where is the problem coming from when we have a centralized production or supply. So now we have seen those core components. We must have IPC program in place. We must have guidelines. We must have training and education. We must have healthcare associated infection surveillance. We must have monitoring of IPC practice. We must have workload and staffing as well as bed occupancy. And then we must have the built-in environment that support implementation of IPC. So once we have all these thought of or starting putting in place, we have to see for the starting program, but also the existing program, how we can improve the implementation of those core components. So WHO also suggests a process how to put in place those components, and it is a careful assessment of the status of IPC program and activities, and should be performed to guide implementation of either minimum requirement or full requirement of IPC core component. When we say minimum requirement, sometimes based on the availability of resources, we may not have all the components in place from the beginning, but from where we start on, we have to have a process targeting to reach the full requirement to be in place for complying with all those IP score components. Therefore, a WHO proposed 5-step cycle of implementation to support any IPC improvement intervention or program. It is a stepwise made by 5 steps. First of all, you have to prepare for action. If you don't have IPC program, you have to prepare to install the program. And whatever you want to do, you have to use that multimodal strategy that we have said. We must see the system in place. We must see education and the training. We must see the way we have to monitor the intervention. We must see the reminder, and then we must have the culture change strategy. So we have to prepare for action. After preparing for action, if you have the program, we can do the baseline assessment of our program. How is it working? What are the necessary infrastructure needed in place? What type of training? So we have a tool based on this core component that we are going to share after the presentation that you are going to use to evaluate your facility and then see different intervention that you're going to put in place using this stepwise intervention, stepwise approach during implementation of those strategy. After doing baseline assessment, immediately develop and execute an action plan. Once you put in place the activities that you have suggested, you now do evaluation of the impact. So it takes some time. WHO suggests also the timeline that you can be doing those different activities. And then we have the second evaluation, and then again you put in place the other action plan to sustain the program again for long term, and then you continue. It is a stepwise, and then it is a cycle. So you have to ensure in step one that necessary resources are in place, human, finance, and infrastructure, so that the program is successful or an intervention is successful. You must have coordination of all those activities, and then identify the role and responsibility for each key player. We must conduct on step two, exploratory baseline evaluation of the current national or facility situation, depending on where you are working as IPC focal person or administrative person, including identification of existing strength and weakness. Here we understand immediately the gaps that we need to address. And then on step three, you use the result of the baseline to assess of the baseline assessment to develop and execute an action plan based around a multimodal strategy, because we have seen that this multimodal strategy is going to involve different key players which are going to help the intervention to be sustainable and to develop the culture change in professionals. And then the step four, we conduct another evaluation, a follow-up evaluation to assess the effectiveness of the plan with a focus on its impact, acceptability, as well as cost effectiveness, because you can bring in intervention which is very costly to the hospital. Immediately, the administration are going to tell you, no, your intervention is very expensive, you can't put it in place. So we have to find other alternative that put in consideration the local context. And then we put again development of ongoing other action plan based on continuous evaluation. We continue as stepwise. So this is how we can go through the implementation of those core components. And from this presentation, we have seen those 8 core components required at the healthcare facility and 6 core components required at the national level. Each of these components work together to develop, support, and measure the efficient prevention of healthcare-associated infection and reduction of antimicrobial resistance. These core components support the technical, non-technical, clinical, social, human resources, managerial, and advocating skills required to create and maintain a functioning IPC program that supports patients and healthcare workers. The multimodal strategy that we have seen that involve the 6 components, you must have a system in place. You must educate and train. You must monitor and give feedback. You must have reminders so that people adhere to the intervention. And then you must target the culture change where people live in that culture of doing good practice in IPC. And then this strategy aim to improve patient outcomes and change healthcare professionals' behavior. The 5 elements of multimodal strategy are this one, as I have said, and implementation of IPC program following the core components suggested by WHO. It must be done stepwise, following the plan for action, baseline assessment, execution of the plan and the execution of the plan, the evaluation of the impact, and again, plan for long-term IPC improvement. So this is the presentation today. Again, I apologize for the interruption due to internet. I thank you and I welcome the questions. Meanwhile, as I communicated, we are going to share with you let me see if I have it, the tool to assess the level of IPC in your facility. We have the national tool, but this one I'm showing is at the facility level. It is a tool also developed by WHO based on these core components. We are going to share with you, And then it is made by different components, the introduction of the tool, and then it is self-assessment tool, or it can be done by someone external. But what we have in place, based on the score we get, we can classify the level of IPC in our practice in 4 categories. We can have inadequate IPC core component, we can have a basic level, we can have intermediate, we can have advanced. So advanced is a good IPC program that is working well following the core component suggested by WHO. So what you are going to see as to do as homework, you see for each core component, do you see my screen? Do you see my screen, please?
No, we don't see
No.
it.
Oh, sorry. Oh my goodness. Sorry again. Let me share again. I'm sorry. So this is the tool I'm talking about. It is a WHO developed tool that we are going to share with you for facility level. They have also national level assessment tool. Do you see now the tool?
Yes, we see.
Yes.
So it has different components. We have introduction, instruction, how to use the tool. What is the purpose of the tool? It is to see the level of implementation of IPC program in your setting. And then we have those 5 stepwise implementation, a stepwise implementation strategy that has to be used in the evaluation of IPC and improving the practice. And then we have who should complete and use this IPC assessment form. It can be healthcare professional or other assessors. And then how it is structured, you have the core component and different questions that you have to answer. Based on the answer you have given, there are scores that are provided. And then the total of the score is done. And then the IPC program can be categorized into inadequate IPC, basic IPC program, intermediate, or advanced. How does it work? They explain your answer by yes or no, or choose the answer. They are so easy to answer, and it is easy to compare between different facilities. For example, if you see the program, how we do assess, they have each questions. For each component, they have questions. For example, do you have an IPC program in your facility? If the program is there, you say yes, but no defined objective. It is there with clearly defined objective and annual activity plan, and then you score 10. So it has different questions for each component, and then later on you do the sum up. For each core, you have a subtotal score, and then you get the final total score at the end. It is a bit long, but it is easy to fill in. We used it for our facility, and it is one of the best tools that you can use to really monitor your IPC program. I want to reach the last part. The last part is when you have the total score. The total score is at 800. So if the facility score less than 200, it is inadequate IPC program. This does not have to discourage anyone. We must have where to start from. The challenge is not to have a goal, not to have a plan. But once you know where you are and where you want to go, it is easy to put in different activities that can lead you to the success. And it is easy to compare with other hospital and request for support. So this is the end of my presentation. We can have some questions and clarifications. I thank you for your attention, and again, accepted apology for internet interruption. Thank you.
Okay, thank you, Dr. Claire. So I see one question from the Obino, who is in the Kenya team. What is the difference between IPCAF and the ICAT?
ICAT. Can I get the word for ICAT?
ICAT means infection control assessment. It's a CDC tool. So what I can say about this tool, the IPCAF, it's a infection prevention and control assessment tool. It's a tool developed by WHO, and it is used for assessing and implementation. They assess the IPC program implementation and the progress. So they classify according to the score. So based on, as Dr. Clary said, it based on the score, and then they classify the level of the program. While the ICAT, which is infection control assessment tool, ICAT, so is a tool developed by CDC, US Center for Disease Control and Prevention. So it's a tool used in hand to assess the practice in healthcare. So they assess the practice, they don't assess the program. So they are specific to the some practice in infection, like hand hygiene, injection safety, isolation precaution. They are specific to some practice in the IPC, while the IPCAF is focusing on the, is focusing on the package of the IPC program. So I don't know if I answered the question. Obino? So if anyone who has a comment about
Yes,
this.
I think that's correct. Because I've been, and I think for the ICAT tool, it's very long. It's in fact, it's about 120 pages, and it is modular based. But for IPCAF, okay, I've never seen it. This is the first time I'm seeing it. I think I've seen it's like 20 pages. I think it's much easier as compared to ICAT tool, which is 120 pages and it's modular based. Yes.
Okay, thank you.
Thank you, Obino. What I can add is, because when we do IPC program, sometimes we appoint focal person, but they don't know really what they have to do. When you ask healthcare professionals what is IPC, they respond hand hygiene, or they say outbreaks. But I've seen WHO try to give us what is really must be included in the program. So this tool for WHO, it is for entire program. If we have everything in place to help the implementers to know what are they really working on. So I think based on the guideline you have, if you choose to follow WHO, you must assess the program, and then you can extract some, while you are developing different tool for assessing the practices. For example, if you find out the tool of WHO for assessment of a given component, like add some of the questions from the other tools so that you standardize at your local context. Because this IPAF, you have to consider local context. That's why they give you the chance to say, we implement the minimum level, but we are targeting to have full level. We do not enter into details of each practice. So that's why sometimes when you are developing your local tools to can learn some questions from each tool to have a final tool that you can be using in your settings. That's my comment.
Hello.
Yes, we hear you.
Thank you so much. Thank you so much, Dr. Marie-Claire, for a good presentation. I have a question about component which will be at the facility level, which was on bed occupancy, staffing, and workload. I'd like to know exactly how many patients per staff. Here, I mean clinician per staff at the health facility. Here, I want to say about nurses, medical doctors, how many patients really to care in order to make sure that the standard are followed, those standards of infection prevention and control. How many patients per staff, per clinician, per nurses, per doctors? Thank you so much.
Thank you, Jerome, for the question. Before you decide, there are some defined standard from WHO, but another consideration that you have to look at is the complexity of the care that are given in a specific area. For example, if you go to ICU, where the patient need cross monitoring and many intervention at once, in many settings, due to lack of healthcare professionals, they require minimum one patient, one nurse per ICU beds. But in routine, other, like if you are, we are determining the ratio in internal medicine where there are no complex care. They can go even to one nurse to three patients, but we have always to consider local context and the funds, if I may say so, the budget and the healthcare professional availability. But in our setting, in most of the situation, we have a very a ratio which is very difficult to follow. We find one nurse is caring for like 50%, 25% per shift, which is really difficult to give injection throughout the day. But normally, you have to consider the workload in the area, and then you have to consider also the the knowledge and the how your staff work. That's why in some area they say 1 to 2 nurse in ICU per patient, in PQ 1 to 2 nurse per patient. But also remember, putting many staff again with few number of patients also can be an increased risk of infection. As you are in the teaching hospital, you know, when we have trainees coming for practicals, we have noticed that if we have like more than 5 to 10 trainees in our ICU, infection increased, because it is also going to have repercussion to the necessary material for IPC. Their knowledge is limited. So to answer your question, you have to consider the local context, the availability of funds, but there are different guidelines about the bed occupancy per and the staff load for each facility. If you find that sometime you can also increase or reduce the workload in the ward based on the professionals' feedback. That's why we recommend that in healthcare settings, administration should encourage the staff to give the feedback based on what they are doing. Sometimes a nurse can complain many times while the ratio which was put there was adequate. But when the healthcare profession are continuously complaining about workload issues, that's where human resource, they have to go down and then do deep assessment and then address the complaint of the staff. So And you see there is someone else to
Well,
put.
has someone asked about how often can we assess the facility using IPCAF?
When you want to do a facility assessment, of course, you have to have a baseline assessment that can be done at first time. And that cycle of improvement, it goes beyond 6 to 9 months or to 12 months. It means that after doing your baseline, identifying the gaps, depending on intervention that you have put in place, intervention goes with the timelines. So you can decide, can we put the intervention, the first intervention that are going to last, for example, 6 to 7 months, and then you can do another evaluation. It depends on intervention and how long it is going to take to finish the cycle of improvement, and you can reassess. But otherwise, you can assess like every year or other 2 years.
Anyone who has a question? Yes, Jacobo from Cameroon. You are welcome.
Thank you, Jean. I'm happy to be here today. You are doing a good job. I just want to make an additional comment on the staffing indicator. It's a very, very complex indicator, and that is also one of the indicators that is hardly met in most of the facilities in Africa. And even when you talk about staffing ratios, you also need to take into consideration the level of the trainings and the experience of the staff. If you have staff that are just newly recruited, they are just starting work, sometimes the number of patients that you can entrust into that staff responsibility have to be fewer because they really don't have the experience. They take a longer time to do what an experienced staff will do in a shorter time. So that particular indicator is very complex. It might appear to be simple, but it's usually very complex. But the most important thing I want to say about bed occupancy is that the emphasis is that we should not have more than one patient per bed. In some facilities, sometimes when it becomes difficult, they will double or even triple patients on one bed. That is really not correct. And then you also need to consider the spacing between the bed. And according to the standard, WHO recommends 2.5 meters from the middle of the bed to the middle of the next bed. But still, as I said, in Africa, most of the countries, that particular spacing is hardly met. So once you have good spacing, then you respect one patient per bed, and then you also respect the environmental cleaning principles and procedures, you are going to cut down your rate of infection significantly. The other indicators about staffing, I know it is difficult to meet, but there are many, many other things that we can do which are relatively simple and can be done if the management actually understand and also buys into the principles and policies of infection prevention. Then I also want to add that we should also take note that whatever you are going to do will depend on the resources you have. And one very bad thing to attempt to do is to do everything at the same time. Always start with one thing at a time, the one that you think is more critical, and the one that you think you have the resources to start with, and the one that is easy to achieve. So do one thing at a time, because when you introduce so many things at the same time, then the staff and maybe the management are going to be kind of overburdened, and then you have a very big probability of failing. And once you fail the first time, when you bring that change again the second time, they will reject it. So be very careful that you don't fail at the beginning, because when you fail at the beginning, then the probability of failing completely becomes very high. Thank you.
Thank you, Jacob. That was on point. Thank you.
Okay, thank you, Jacob. So Dr. Kireri, could you stop sharing the screen so that we can request everybody to switch on the camera and take a picture. If there is no one who has another comment or question. So can you switch on your camera and take a picture for today? So thank you all for being with us today. So let's have today pictures. So and we will have next session in the coming 2 weeks. Our next session will be on the 26th this month. So you are all welcome into our session. So thank you so much for attending our session today. See you in the next session on the 26th. Thank you. Bye.
Thank you very much. Thank you very much.
Goodbye.
Thank
you.
you.
Goodbye.
Bye.
Bye.